Thank you, Dr. Cunha, Dr. Palabrica, and Dr. Jose online. Okay. So now we move on to our fourth case discussion. This case is entitled the computer-navigated scoliosis surgery in a patient with adolescent idiopathic scoliosis associated with bilateral congenital hip dysplasia at Vicente Sotto Memorial Medical Center, and will be presented by Dr. Erika Paulina Stefani H.
Good afternoon, everyone. I'm Erika C. I'm the current fellow of the Vicente Sotto Memorial Medical Center. Today, we will be presenting a case of a 15-year-old female who presented to our clinic with back pain and deformity for 3 years. So initially, this patient presented with occasional dull back pain with progressive deformity of the back with worsening of the pain. She initially sought consult with a private physician who requested for thoracolumbar x-rays and pelvic radiographs with an impression of adolescent idiopathic scoliosis and then concurrent DDH bilateral. She was then advised for surgery. However, this patient was not compliant. Until 1 month prior to consult, when there is an increasing in the severity of the low back pain with a 9/10 pain score and dysphagia and dyspnea on recumbency, hence consult and preparation for surgery. So for the past medical history of this patient, she was initially diagnosed with DDH incidentally when the patient was 7 years old. She reports a history of allergies to dust and seafood and a menarche of 13 years old. So the natal history of the patient, she was delivered full-term via cesarean section due to breech presentation, and the mother reported taking phenobarbital while she was pregnant. Other than that, the past medical history of the patient was unremarkable. So we see the physical examination of this patient in our clinic when she presented with a Trendelenburg gait, however with no limb length discrepancy, a right truncal shift, and a right-sided prominence upon Adams bending forward test with a scoliometer reading of for the thoracic 21 degrees and for the lumbar 7 degrees. She has a waist crease more prominent than the left and a shoulder asymmetry with the right being higher. The physical examination for the motor and sensory, as well as the other neurologic examinations, were unremarkable, as well as the laboratories of the patient. So these are pre-op admitting radiographs. You can see a Cobb's angle of the main thoracic measured at 60.05 with the upper end vertebra at T5 and the lower end vertebra at T12 with a stable vertebra at L1. So for the Cobb's angle of the proximal thoracic and the thoracolumbar curves, we have a value of 9.85 and 7.26. For the right bending and left bending, we have the following corrections of 45 and 15%. And the minor curves displaying flexibility. So this patient displays a neutral coronal balance and an AVT ratio of 1.45 with less than 20 degrees Cobb's angle for the sagittal profile, and an SBA of 2.04 cm. For the pelvic incidence and the lumbar lordosis mismatch, we calculated a value of 26.88 and an adequate shoulder balance restoration for the coracoid height difference and the clavicular angle. So this patient was also classified radiographically with a Sanders 7 maturity. So our assessment was an adolescent idiopathic scoliosis, like a classification 1C and King classification type 3 and a Sanders 7 with the concurrent developmental dysplasia of the hip bilateral. So for the goals of our surgery, these are the following goals with key points to prevent the curve progression and to maintain a coronal and sagittal adjustment of the spine. For our planned procedure, we have a computer-assisted scoliosis surgery with posterior spinal fusion with selective thoracic fusion at T4 to T12. Since our patient has fulfilled the requirements for a selective thoracic fusion for preservation of the motion segments in the lumbar area, since this patient already has a concomitant hip problem. So our conduct of surgery was as follows. We place the patient prone under general anesthesia with intraop neuromonitoring with the screws inserted under navigation. You note the saturation of the screws to compensate for the shorter level of fusion. And then we also performed a 5-level ponte osteotomy for more reduction maneuvers. For our post-op radiographs, we note a correction of the preoperative Cobb's angle of 60.05 to a post-op Cobb's angle of 10 degrees with the following thoracic and lumbar lordosis. We note an increase in the post-operative lumbar lordosis. The post-op SVA was still within acceptable limits, and the pelvic incidence lumbar lordosis mismatch improved to 8.81. So these are the comparison of the gross pictures of our patient from first day post-operative until 1 year post-operative. Okay. So these are the patient's post-operative radiographs from 1 year post-op. We note a maintenance of the SVA within acceptable limits, as well as the Cobb's angle and the thoracic kyphosis. The lumbar lordosis increased somewhat to 75.51, with the pelvic incidence mismatch at 6.91. The sacral slope is increased at 57.69, and the pelvic tilt is 24. So there is still the presence of the bilateral dislocated hip of the patient. So for a quick discussion, in patients presenting with type 4 CROW type 4 DDH, there seems to be an exhibited abnormal spinopelvic alignment characterized by an anterior pelvic tilt and lumbar hyperlordosis. So accordingly, we must also note that the pelvic tilt and the thoracic kyphosis, and not just the pelvic incidence and lumbar lordosis mismatch, is critical in maintaining sagittal balance, especially when there is a PILL mismatch of more than 10 degrees. So currently, the current incidence for patients presenting with AIS with concurrent bilateral hip dysplasia is noted to be 3.5 to 6.4% in current literature, and there seems to be an increase in the rates of acetabular overcoverage, which can predispose the patients to additional hip pathology, more commonly recurrent hip dislocation. So moving forward for this patient, we referred her to the joint service, and there seems to be a consensus that the hip pathology would need to be addressed when the patient develops into adulthood and becomes symptomatic. So the patient should have total hip arthroplasty if the patient becomes symptomatic in the future. So for a take-home message, there should be an optimal preoperative planning, which should address correction of both the coronal and the sagittal parameters in AIS surgery, and the correction of the sagittal plane balance is the most reliable predictor of the clinical symptoms post-operatively. Thank you.